This PowerPoint was developed using slides copyrighted by Elsevier and images off of Google. My use of them in this presentation is legally allowable as fair use for educational purposes. Nursing 150, Chapter 48, Musculoskeletal Dysfunction. We're going to start by having a discussion on immobilized children, since musculoskeletal conditions frequently are the cause of immobilization. So this is one of the most difficult aspects of illness in a child, because children are naturally mobile. Different reasons that immobility can occur are cognitive defects, degenerative disorders, infections or injuries that impair the skin, neuro, or musculoskeletal systems, and therapies that prolong immobilization. Immobilization greatly affects the musculoskeletal system, as we're going to see here. Some of the physiologic effects are decreased muscle mass and strength, atrophy, loss of joint mobility, bone demineralization, and a negative calcium balance. There are metabolic effects from immobilization. Those include decreased metabolic rate. So we talked before about how immobilization can cause obesity in some children, negative nitrogen balance, hypercalcemia, and decreased production of stress hormones necessary for growth. Cardiovascular effects of immobilization include decreased efficiency of orthostatic neurovascular reflexes. What does that mean? Well, we have our orthostatic neurovascular reflexes that are able to maintain a normal heart rate and blood pressure with changes in position. So if we are not adequately maintaining those, someone can have what's referred to as orthostatic hypotension or orthostatic syncope, where when they stand up, their blood pressure drops and they may feel like passing out or actually pass out. And if a child has been immobilized for quite some time, they are not as resilient to position changes. Diminished vasopressor mechanism. So this is the ability of the cardiovascular system to maintain heart rate and blood pressure. Altered distribution of blood volume. So if you're laying in one place for too long, it's going to alter how your blood is distributed, in part because of venous stasis, which is our next bullet point. So venous stasis, blood pooling, not very good movement back through the venous system. And then dependent edema, which is often associated with venous stasis as well. Respiratory effects of immobilization include decreased need for oxygen, diminished vital capacity, so they do not have the capacity to take as deep of an inspiration, poor abdominal tone and distension, and that relates back to some of the muscles that are incorporated with respiration, mechanical or biochemical secretion retention. So what does that mean? Well, that's in reference to mucus secretions. So inability to move mucus secretions effectively, and just general loss of respiratory muscle strength. GI effects of immobilization, distension caused by poor abdominal muscle tone, difficulty feeding in a reclined position. So if they're not able to be upright, gravity is not helping them. Constipation and anorexia, which is loss of healthy appetite. Urinary effects of immobilization, alteration of gravitational force. So they do not have gravity working in their favor to help move the urine through the urinary system. They could have difficulty voiding if they're in this flat position. Urinary retention. Impaired ureteral peristalsis. What is that? Well, that is peristalsis is the smooth muscle movement, and we're talking about the ureters. So if the smooth muscle movement of urine from the kidneys through the ureters to the bladder is impaired, they can have a backup in the kidney that's called hydronephrosis. And urinary tract infection, of course. Skin effects: decreased circulation and pressure, leading to slower healing times, being prone to pressure ulcers. There are a lot of psychological effects of immobilization. Decreased environmental stimuli. We learned about how important proper stimulation is for cognitive development. Altered perception of self and environment. So perception of self and environment is very important to the psyche, and we learned about how that evolves in the developing child. Increased feelings of frustration, helplessness, anxiety, depression, anger, aggressive behavior, developmental regression. So instead of continuing to progress forward in development, regressing back to an earlier time. Family effects. This disrupts family function in a number of ways. Logistically, they need to figure out who's going to be the caregiver of this sick, immobilized child. Often, extended members of the family have to pitch in to provide physical help. Home care needs arranged. The coping skills of the family can be strained by this. Many times, both individual counseling and family group counseling is advised for parents who are being affected by a sudden acute or new chronic illness that involves immobilization. So, general care management for the immobilized child. For one thing, we're not going to neglect any of the body systems that may be affected. We're going to holistically consider how all systems are involved. We're going to address neurologic and electrolyte impairments. We're going to monitor skin and do meticulous skin care, DVT prevention, mobilization, compression if indicated, high protein, high calorie foods to maintain nutrition, encourage activity within their ability. Play therapy is an actual field. There is a field of study or practice called Child Life that incorporates actual play therapy. And this could be something simply as getting the child out of their room, get them out to see other environments, other people. So now we're going to talk about causes for immobilization and musculoskeletal alterations. And we're going to start by talking about traumatic injuries here. So there are injuries to the soft tissues, which are muscles, ligaments, and tendons, or what we'll cover first. And these are very common injuries that can occur during play, during sports injuries, or they could occur as a result of abuse. We have our little review here of the musculoskeletal anatomy. So where the tendon connects, muscle is part of the soft tissue. We can have muscle contusions, ligaments. Ligaments can be sprained, and then the epiphysis, which is the growth plate, that can actually be injured in a way that causes it to separate from the rest of the bone. So let's talk about contusions. A contusion is a damage to soft tissue, subcu tissue, or muscle. And what happens during a contusion is that blood escapes into the tissues and causes ecchymosis, and this is what causes that black and blue bruising color. It's often accompanied by swelling, pain, and decreased use of the area. This is a significant concern with crush injuries. Dislocation. Dislocation is a displacement of the normal position of bone ends or a bone end into a socket, and it occurs when the force of stress on a ligament is sufficient enough to cause displacement. It involves a lot of pain typically, and the pain increases with movement of that joint. This happens a lot in children with Down syndrome and connective tissue disorders. Hip dislocation is particularly concerning because when there is a hip dislocation, because of the positioning of the blood supply network, there is a potential loss of blood supply to the head of the femur with many of these dislocations. So if it's not put back into place fairly quickly, there can be necrosis or tissue death to the actual head of the femur. Dislocations can spontaneously reduce themselves, or they might require a manual reduction where it's actually being forced back into place. This is painful and needs done under sedation. Sprain is trauma to a joint from a ligament partially or completely torn or stretched by force, and it can also be associated with damage to blood vessels, muscles, tendons, or nerves. Presence of joint laxity is an indicator of severity. So if someone sprains their ankle and then the joint is very loose to passive range of motion afterward, that indicates that there was a more severe stretching or tearing of the associated ligaments. Sprains usually involve a rapid onset of swelling, along with disability or decreased ability to use the affected joint. There are times, frequently, when a sprain actually on the outside looks worse than a fracture. A strain is a microscopic tear to the muscle unit. It's similar to a sprain. It's swollen and painful to the touch, but this usually occurs over time. Onset isn't as rapid as sprains. So with a sprain, you can think of a common one as being like an overturned ankle, whereas a strain could be overuse of a particular muscle, such as in a sports or exercise activity. So for therapeutic management of soft tissue injuries, we use the mnemonic RICE. So that stands for rest, ice, compression, elevation. So they're going to rest the injured part, ice it immediately, and we apply ice for a maximum of 30 minutes. Compression with an elastic ACE bandage and elevation of the extremity to reduce swelling. And then after the RICE, we do immobilization and support. So that's splinting as appropriate to the injury. So that might be something as simple as an ACE wrap. It may be something a little more involved, such as a knee sleeve or a supportive air cast, or in the case of an upper extremity, perhaps a sling. So moving away from the soft tissue injuries and moving on to fractures. Fractures are a common injury in children. Fractures are rare in infants, and anytime you see a fracture in an infant, that warrants investigation. That's a red flag. That's something that should be reported to Child Protective Services so that they can investigate and assure the child's safety. Also, spiral fractures that are inconsistent with the reported mechanism warrant an investigation as well. So a spiral fracture is the spiral pattern caused by a twisting. So if a child says that his sibling slammed his arm in the door, but the fracture is actually spiral, that is inconsistent, because with a door slamming injury, you would think of more like a crushing or a oblique or comminuted fracture, but not a twisting spiral motion. So anytime the story doesn't match up to the injury, that's suspicious. And there are certain experts who feel that all spiral fractures are suspicious and should be investigated. We can take a more moderate approach and ask, is this consistent with the reported history? The forearm is the area that's most frequently broken in childhood due to childhood activities. And during school age for children, most fractures are caused by biking accidents or sports injuries. So here we have our different types of fractures. A simple or closed fracture does not produce a break in the skin. We'll have some photos here in a moment. An open compound fracture involves a fractured bone protruding through the skin, so that's going to require surgery. Fractures can be complicated where bone fragments have damaged other organs or tissues. And a comminuted fracture, small fragments of the bone are broken from a fractured shaft and lie in surrounding tissue. So here we have a couple different fracture lines: buccal fracture, green stick, complete with periosteal hinge, or other types as well. So our fracture lines can be transverse, which is crosswise at right angles to the long axis of the bone, so pretty much straight across. Oblique, which is horizontal, or the spiral circular twisting. The weakest point of long bones are the cartilage growth plate, the epiphyseal plate. This is a frequent site of damage during trauma because it's the weakest point and it's slightly mobile. It may affect future bone growth, and treatment of a growth plate injury may include open reduction and internal fixation to prevent growth disturbances. And what that means is open reduction is basically surgically putting it back into place, and an internal fixation is applying hardware inside to keep it fixed in place, so screws and plates. And there is a Salter-Harris classification system that you're not expected to memorize, but just be aware that it exists. And this is the Salter-Harris different types of growth plate fractures. So bone healing and remodeling in children is a lot more rapid than it is for adults. Among infants, it's a matter of 2 to 3 weeks. Early childhood, 4 weeks. Later childhood, 6 to 8 weeks. And adolescence, 8 to 12 weeks. So for diagnosis of fractures, we're going to take a history of mechanism and get an x-ray. And anytime we have a young child who refuses to walk or bear weight on an affected extremity following any sort of suspected or reported trauma, we're going to get an x-ray of that. The goals of fracture management are reduction of the fracture, so realignment, immobilization, so making sure that it's going to keep still for healing, restoring function, and preventing deformity from improper healing. So when we're assessing a fracture, we want to do a neurovascular assessment. We want to do this before we're applying any sort of splint or cast, and then again afterward. And we're going to use the 6 P's, which are pain, pallor, pulse, paresthesia, paralysis, and pressure sensation. So for casting of fractures, initially in first aid or emergency room, a fiberglass and ACE wrap splint is typically applied initially. So even though it's secured with an ACE wrap and ACE wrap closures, we need to advise the child and the family that this is not to be removed. This is functionally a cast. And then a non-removable fiberglass cast will be applied by an orthopedist. For care of splints and casts, they're not to get wet. They're not to stick anything down there. And sometimes we think of small children wanting to stick little things down in there, M&Ms, small toys, just because that's what kids do, right? They stick things in the little holes. But also, for older children, it's a great temptation to want to stick a pencil or a coat hanger down there to scratch an itch, and that's a huge no-no. If the edges of the cast at the top and bottom of it are scratching the skin, we may apply additional gauze or cushioning around the edges as needed, just kind of tucking it around there. Fingers and toes should stay warm and pink with intact sensation and brisk capillary refill. If the child reports feeling a hot spot, like one area of the limb feels hot inside the cast, up against the cast wall, that is an indicator of potential infection. And then cast removal is to be done in the office by a special saw. We don't want kids and families trying to cut their own casts off at home. That can be potentially traumatic. Compartment syndrome is a condition that can occur due to increased pressure tissue swelling. It occurs most commonly in the forearm and lower leg with fractures, and in particular, this is a risk after a cast is applied. And this pressure buildup can cause long-term tissue damage if it's not relieved. The signs and symptoms are, this is extremely painful. The pain is worsening, and it's unrelieved by pain meds. So if a child has a fracture, they should get a little bit of relief with the cast being put on, and then they should get even more relief with pain meds. If they have been casted and they have their pain meds, and as the days go by, their pain is getting worse, that is a bad sign. That is very suspicious for compartment syndrome. Increasing paresthesia. So maybe they had some tingling in their fingers initially from the injury. That should be getting better. Compartment syndrome, it would be getting worse. Decreasing range of motion of the joints distal to the injury. Another sign of compartment syndrome. And then increasing cap refill time. If any of these occur, the cast needs to be removed. Compartment syndrome can occur from a cast being too tight, or it can occur from the injury itself. So when we remove the cast, that doesn't always necessarily eliminate the compartment syndrome. And compartment syndrome that does not improve following cast removal sometimes requires a procedure called a fasciotomy, where actually the limb is surgically cut into, a linear incision is made through the subcutaneous and muscle tissues to leave it open to relieve some of that pressure. In children, skeletal traction can be applied to fractures. This is usually for more severe fractures. It is to stabilize and align the bone fragments, or it can be to enable closer evaluation of the injured site. So, for newer technology, we don't have to keep them on bed rest. We now have orthopedic fixation devices that actually allow them to be mobile, and we'll have a picture of that shortly. The purpose of traction is to relieve fatigue in involved muscles. So there's a lot of muscle spasm involved when a joint tries to, when a limb tries to stabilize its broken pieces. It aligns the distal and proximal bone ends into the proper position, immobilizing the fracture site, preventing deformity, and this reduces further injury and reduces muscle spasms. So here's a visual of what that accomplishes when you have the traction pulling in two different directions to align the long bone. So a couple different types of traction are Bryant traction, where both legs are hanging from the ceiling, Buck's traction, which I have a photo of here for the femur, legs off the bed, Russell traction, balance suspension involving the entire bed, Gardner-Wells tongs, which is a type of cranial traction, and then cervical traction in the form of a halo brace or vest. So here's Buck's traction. Here's what that looks like. So this device is applied and weighted so that it is pulling. And then this is your halo traction. This little girl does not look too thrilled to be wearing this, but this is on a vest with the applied to the halo on her head, and this is actually pulling apart her cervical spine to apply cervical traction. So while traction looks like a torture device, in talking to patients who've been in traction, if they're injured enough to warrant this, the presence of traction affords them great relief because the muscle spasms are very painful, and this is taking the work off of the muscles to do this. So for care of the child in traction, we're going to regularly assess the child and the apparatus. Skeletal traction is not to be taken apart by the nurse. It's to be taken apart by the licensed provider when it is time. Pin site care, some of these traction devices involve pins that are screwed into the bone and protruding out of the skin. Not all traction involves that. Some traction is non-invasive, but if there are pins coming out of the skin, cleaning around them with antiseptic swabs, keeping them clean, keeping those sites clean and infection-free, pain management, ensuring that the weights hang freely. So in this picture back here of our Bucks traction, okay, there's no pins in this. This is on with a wrap around the lower leg, but we have our weights that hang off the end of the bed. If those are touching the floor, you're not going to get the same effect. So the process of separating bone to encourage regeneration of new bone in an empty space is called distraction of a fracture. And this can actually be done for therapeutic reasons when limbs are of an unequal length to elongate the shorter limb. Or this can be used for perhaps deformed limbs who healed incorrectly from another injury. And this is accomplished with an external fixator device. And this is a photo of a little girl doing her therapy with a fixator device in place. So these do have pins that go into the bone and protrude out through the skin. So she obviously has good pain control because she is smiling for her picture, unlike our grouchy little girl who was in halo traction. Amputations. Amputation is a traumatic loss of a limb, and it could be by accident or it could be done for therapeutic purposes. And following amputation, there may be further procedures required for proper stump shaping in order to be able to fit into a prosthetic. Following amputation, the special concern with pain management is phantom limb pain. And phantom limb pain, as you may know, is when there is a sensation of pain in the limb that is no longer there. So it's no longer there, but that is the sensation. Sports injuries. So all activities have the potential for injury, whether they're recreational or competitive. And a lot of some sports involve more rough contact than others, and that's why we call them contact sports, i.e. tackle football, as opposed to non-contact sports like competitive swimming. So there are some that are slightly more risky than others. There are variables in the equipment used. What type of equipment are they playing with? What type of safety equipment is available to them? And are they wearing it? Is it properly fitted? And then there's also injuries called overloading and overuse injuries, which we'll get into next. So overuse syndromes, just as a background, young athletes are forced to train long and hard. And performing the same movements repeatedly has the potential to cause this microtrauma in the musculoskeletal structures. This could be friction rubbing, or it could be traction from repeated pulling on, or it could be repetitive loading, which it would be like a stress fracture. We're going to move on now to developmental dysplasia of the hip, also known as congenital hip dysplasia or congenital hip dislocation. This has an incidence of 1.5 per 1,000 live births, and girls are more commonly affected, and there does seem to be a strong family history with this condition. So we have an illustration here of the different degrees of developmental dysplasia of the hips. The first image being the correct placement of the femoral head in the acetabulum of the pelvis. You can see in dysplasia it's not as tight of a fit, it's somewhat loose. We can see in subluxation that it is starting to move out of the acetabular space. And then with dislocation, we can see that the ball head of the femur is completely out of joint and that the ligament is being pulled on. So as far as the different degrees, breaking it down here, the subluxation was the incomplete dislocation, that early pulling away. There's a degree even before that called preluxation or acetabular dysplasia. This is the mildest form with a softness or a thinness of the acetabular roof, so that socket there. The femoral head does remain in there, but this is something that can be detected on X-ray and could potentially progress to a worse form. When full dislocation occurs, the femoral head loses contact with the acetabulum and is displaced posterior and superiorly, so back and up. Ligaments become elongated and taut. So manifestations of this in the newborn infant are hip joint laxity, a shortened limb on the affected side, restricted abduction of the hip on the affected side. So remember, abduction is like when it is moved in an outward motion. So turning the hip out like a frog leg, or doing like a jumping jack outward. That motion is restricted. Unequal gluteal folds, and then positive Ortolani and Barlow tests. So Ortolani and Barlow maneuvers, by way of review here. On the far right, item D is the Ortolani maneuver, where when you adduct the hip in a frog leg position, that it feels very loose. And then Barlow's maneuver in the middle section there, B and C, is when you adduct it back together, and it goes back into place. But in some cases, it does not go back into place, and in those you will see an asymmetry on the level of where the knees fall. So when we're doing our newborn infant assessment, we're manipulating the hips this way to feel for any laxity, any clicking or grinding sensations, and then we're checking for the symmetry at the level of the knees, and then the gluteal folds symmetry as well, and the limb symmetry. So early intervention is essential to keep function of the hip. If this is diagnosed before 6 months, they will apply something called a Pavlik harness to keep the hips abducted in such a way that they can heal and grow stronger together. And this is an illustration of that. In the toddler or infant age 6 months to 24 months, this may be the milder forms that aren't recognized until the child is trying to learn to stand and walk. And at this point, at this age, they're going to usually require some sort of casting. So a spica cast, because they're too big for that infant Pavlik harness. So I guess I don't have an image of that, but very similar to the Pavlik harness, just in a cast with a bar connecting the thighs. In the older child, older than 2 years old, they're usually going to need some sort of surgical correction. And the warning there is that if they wait until after 4 years of age, it becomes much harder to correct. Clubfoot. Clubfoot is a complex deformity of the foot and ankle. And you don't need to memorize all of these terms here, but just be aware that it can involve inversion or bending inward, eversion or bending out. It can involve plantar flexion with the toes lower than the heel, or dorsiflexion with the toes higher than the heel. And these are all at rest, deformities at rest. So here we have the first one there with the inversion. So there are different degrees of, there are different classifications. There's the mild positional, and this one can be corrected fairly easily, and it could be corrected with passive exercises or serial casting. There's syndromic, which is associated with other congenital abnormalities. So let's say there's a child that has a trisomy, and they have a lot of different things. They have congenital heart, they have kidney problems, and they just happen to have clubfoot as well. Well, this would be a syndromic example, and these are going to need surgical correction, and they have a high incidence of recurrence and needing repeated surgeries to recorrect. And then congenital idiopathic, something that they're born with, but we're not necessarily sure exactly why it happened. And this is a bony abnormality that needs surgical correction as well. So there are 3 phases to therapeutic management. So there's the correction phase, the maintenance phase, and then the regular follow-up phase. So during the maintenance phase, the focus is on regaining normal muscle balance and function, and the good follow-up is to prevent recurrence. Ponseti casting is the type of serial casting that they do in stages to force it to correct itself. And here's an example of a very young infant in bilateral Ponseti casts. Very similar to clubfoot is metatarsus adductus. This is a fairly common congenital foot deformity. It may be related to abnormal uterine positioning, and the management depends on the extent. It talks about teaching for parents. Many times parents whose infants are otherwise healthy but are born with a foot deformity could be upset and ask why, and just explaining that this particular one could be due to how they were positioned in the uterus when the foot was growing, or a lot of times we don't know why these things happen. And this one as well, different varying degrees of management, serial casting being potentially one of them. Skeletal limb deficiencies are also called reduction malformations, and these are a wide range of variations and severities, and it usually involves some sort of underdevelopment of an extremity in utero. Sometimes it's a constriction by an amniotic band that causes prenatal destruction of a limb. Other abnormalities may or may not also be present. So As far as our terminology goes, amelia is the absence of an entire extremity. Macromelia is the partial absence of an extremity. And phocomelia is the deficiency of the long bones, so the hands and feet are attached nearer to the body, also known as seal limbs. You can picture that in your mind. So for therapeutic management of congenital limb deformities, we're going to introduce prosthetics as soon as possible. The sooner a child can be outfitted with a prosthetic, this maximizes their exploration of the environment and their development, both motor and cognitive. As far as the seal limbs go, they can surgically amputate the digits and then reattach them, lengthen and reattach, or they may choose not to reattach and just form a stump for use with a prosthetic. Now we're going to talk about the osteogenesis imperfectas. So osteogenesis imperfectas are a group of inherited disorders of connective tissue disorder. And there are, some of the types are genetically dominant and others are recessive. There are 8 types with subtypes, and we're not going to go through all of them, but we are going to bring out a few of the main ones. All of these are characterized by very fragile bones. They have defective periosteal formation and reduced cortical thickness of bones. Type 2, know that one is always lethal with multiple fractures present at birth. These patients also have hyperextensibility of their ligaments, so oftentimes a lot of joint laxity, they're double jointed as the term goes. And then these can be with or without dental involvement depending on which type it is, and with or without a blue tinged sclera of the eyes depending on which type they are. Therapeutic management of osteogenesis imperfecta is primarily supportive care. Intravenous biphosphonate therapy has been found to help strengthen the bones of some of the types. Anytime multiple fractures occur in a child, either at once or maybe a history of multiple different ones at different points in time, we're going to rule out 2 things. We're going to rule out, first of all, osteogenesis imperfecta, brittle bone disease, and we're going to rule out child abuse. So a lot of times, this is the thought process that is happening in a provider's mind at the time when this is diagnosed. A rehabilitative approach needs taken to prevent further complications, and this includes prevention of positional contractures and deformities, prevention of muscle weakness, and prevention of malalignment of the lower extremity joints. Pearse disease is an idiopathic necrosis of the femoral head. So the femoral head turns black and dies and loses blood supply, and it's idiopathic in that we don't know why it happens. But it seems to happen in children ages 2 to 12 years of age. It's actually most common among white males ages 4 to 8 years of age, and we're not really too sure why. 1 out of 10 cases, it happens bilaterally. In most cases, the bone age is delayed, and the cause, the exact mechanism, as I mentioned earlier, there's a ischemic necrosis, and this is because the circulation, the blood supply to the femoral head is somehow interrupted. So the goal of treatment is to keep the head of the femur intact, and many times this involves some sort of open reduction, internal fixation, so surgery to apply hardware. There's going to be rest, no weight bearing initially. NSAIDs are found to help in many of the cases. In others, they're able to manage it non-surgically with a non-invasive device and do traction at home. Scoliosis is a very common spinal deformity. It's the most common spinal deformity, and it involves anywhere from 1 to 3 of these planes. Lateral curvature, so S-shaped curvature to the side. Spinal rotation, so part of the spine is twisted, causing rib asymmetry. Or thoracic hypokyphosis, so less of the natural chest curve. Often all 3 of these are present, but in milder types there may be only one of these present. Scoliosis can be congenital, present at birth, or it can develop later during childhood. And here is an illustration of a young man who has all 3 of those different malignments. He's got the lateral curvature, and he's got the spinal rotation, and he's got the reduced chest curve. So this becomes most noticeable after the pre-adolescent growth spurt. It's easier to visualize. Most of the time we don't know what caused it. School screenings are controversial. There was a time when at about 10 to 12 years old, all of the kids were getting their backs checked out by the school nurse, and they would line them all up and they would say, okay, you walk and then bend down and touch your toes and slowly roll back up again, and we're going to see how straight your spine is. Well, that's been questioned for accuracy. There's a lot of cases that could not be caught that way, and then there were a lot of ones that were allegedly a positive screening, but then it turned out to be nothing. So for that reason, a lot of schools are getting rid of bothering with that. But checking for spinal alignment is definitely going to be part of your primary care well-child visit, head-to-toe assessment. For diagnostic evaluation of spinal curvatures, they're going to get x-rays in a standing position to determine the degree of curvature. The examiner may be able to see asymmetry of the shoulder height, of scapular or flank shape, or hip height, and this will be confirmed on x-ray as well. In addition to the main curve, sometimes there's a compensatory curve in the other direction to try to align, and that is the S shape. Therapeutic management is going to be a team approach. There's going to be braces, and here we have an image of a couple of young ladies in their back braces. Exercises, or for very severe cases, surgical fusion. So we're going to talk about some infections. Osteomyelitis is an infectious process in the bone. Staph is the most common causative agent. Diabetics are predisposed due to their poor circulation. And then acute osteomyelitis can become chronic. So the signs and symptoms begin abruptly, and they may resemble the symptoms of arthritis and leukemia with bone pain. There may or may not have an associated soft tissue wound or entry point. They're going to have a very elevated white blood cell count with or without fever. Bone cultures can be obtained from needle biopsy. And this is, the warning is that x-rays may appear normal at first. So if a child is continuing to have pain at that site, an elevated white count and fever, but the x-ray was normal, that's when we're considering doing the needle biopsy to check for that and try and culture that and see what it grows. A bone scan will show this, and also is definitive for diagnosis. So the treatment for this is prompt, vigorous IV antibiotics for anywhere from 1 or more months. Intravenous antibiotics don't travel to the bone as readily as they travel to other areas, and that's why it takes so long to really reach there and accomplish the desired effect. If a pus pocket is identified, they may surgically go in and drain that. Complete bed rest and immobility of that limb is recommended. Pain management is going to be a factor. And since they are receiving IV antibiotics for so long, they're going to need some sort of long-term intravenous access, so a PICC line or Mediport placement. We're going to make sure they get good nutrition, so high protein, high vitamin C to promote healing, and they're most likely looking at an extended hospitalization unless they are able to be stabilized enough to go home and to continue to receive antibiotic therapy at home for the duration of the treatment period. Skeletal tuberculosis is dissemination of active tuberculosis into the bones and joints. So you may recall before when we talked about tuberculosis, how tuberculosis most oftenly activates in the lungs and becomes active pulmonary tuberculosis, but how it can really go to any organ in the body. And so skeletal tuberculosis is when it invades the bones and joints. The most common sites are fingers, the toes, and the spine. And just know that this is not common in the United States. Juvenile arthritis. Juvenile arthritis is used to be called juvenile rheumatoid arthritis. We now call it juvenile idiopathic arthritis. It's not always believed to be rheumatoid in nature, so this is why we are now calling it idiopathic. Many patients do have an immunogenic susceptibility, so that means like genetically there's something with their immune system that makes them susceptible, and we think that there's an environmental trigger that pushes them into that, but we haven't fully identified those mechanisms yet. The peak onset is 1 to 3 years of age, but it's not uncommon for this to not be diagnosed until later, and then to retrospectively look back and say, oh yes, well this actually did start back in the toddler years. So it's actually a group of diseases, and at the time of onset, there's often all these different things going on at the same time as well. High fever, rash, enlarged spleen and liver, could be pericarditis, pleuritis, which is inflammation of the friction lung tissues, and large lymph nodes. So we say it's not truly rheumatoid in the fact that when we do blood work, 90% of these children do not have a positive rheumatic factor in their circulation. The symptoms are joint pain, decrease in activity, and there is chronic inflammation of the synovium tissue layer with joint effusion, destruction of cartilage, and ankylosis or weakening of joints as disease progresses. There are no definitive diagnostic tests for juvenile idiopathic arthritis. There's an elevated SED rate, ESR in some cases. There's a presence of ANA, antinuclear antibodies in some cases. But these are not definitive because these are not specific and these are not present in all cases. During exacerbations, white blood cells do tend to be elevated. So diagnosis is really based on clinical condition, and it's based on a set of criteria that's been lined out by the American College of Rheumatology. There is no specific cure for juvenile idiopathic arthritis. The goals of therapy are to preserve function, prevent deformities, and relieve symptoms. Most of these cases are going to be managed outpatient. This would rarely require some sort of hospitalization. Combination med therapy is highly effective, and it can involve any combination of any of these. They're NSAIDs. So when we say NSAIDs, a lot of times we think about ibuprofen, but these could be your longer acting ones like Celebrex and Mobic. Disease-modifying anti-rheumatic drugs such as Imuron, even though they're negative for rheumatic factor, many cases do respond to these type of drugs. Biologic disease-modifying anti-rheumatic drugs such as methotrexate, Humira, and glucocorticoids, steroids, prednisone, but caution is to be used with that because, as we know, long-term use can take over and actually turn off your own adrenal glands and create those Cushingoid side effects with the moon face and the elevated blood glucose level. Physical therapy and occupational therapy are very helpful. Pain management with adjuvants. Promotion of general health, not neglecting the rest of the body systems because of what's happening musculoskeletally. Facilitating compliance with drug regimen. So it can be hard for kids to stay compliant with their drug regimen. And encouraging the use of heat for pain and exercise to keep mobile, and emotional support for the child and family.